recorded the right way. There we go. It says we are being recorded. Okay. All right. So let me see if I can share my laptop with you. All right. Can you guys see my PowerPoint?
So we need to continue on that?
Oh, can you see my PowerPoint?
Yes.
Yes. No, says the meeting is being recorded.
What did you say, Punya?
They say the meeting is being recorded, so we need to continue it, right?
Yes.
Okay. It does not go away. Oh, yeah. Here we go.
All right. Punya, can you see the PowerPoint?
Yes, I did.
All
Yes.
right. Excellent. All right. So today we're going to talk about the digestive system. Lots of terms involved in this too, apparently, that the digestive system literally runs from your mouth all the way to the rectum and anus. So, of course, there is a ton of information on this graphic, which you don't need to know all of it. They go into a really heavy amount of A and P in this, which drives me crazy. So with that said, this is just a funny thing I put in. My dear Watson, this is what you call the path that food takes through the body. The alimentary canal, not the elementary canal, but the alimentary canal. Okay, so the organs of the digestive system start in the mouth, okay? They follow through the esophagus, through the stomach, and through the intestines. Now, the liver on the left side, or excuse me, the right side of this, I like to always include that the liver is here, and the whole point of the liver in digestion is it secretes things that help us break down fat, okay? So that's why it is here too. So the anatomy of the large intestine. The large intestine is about 6 feet long, okay? And I'm going to start backwards. So here is where the rectum and the anal canal are. The rectum and the anal canal are only about 2 inches of the end of the large intestine, okay? So we have the descending colon in your body. This part, it works down, okay? Then we have the transverse colon. That goes across your abdomen, okay? And then the ascending colon, this is what hooks to the small intestine, and this is where your appendix is. Right where your appendix is right where the small and large intestine meet, okay? So when they talk about the hepatic fixture, this is where the liver connects to secrete things in. This is the splenic fixture. This is where the spleen is fixed to it. So I like this because it gives you a little bit more idea of how your large intestine spreads across your stomach. Typically when patients present with a stomach ache, it's because food is stuck in this transverse colon area, okay? So again, the appendix, it connects where the large intestine meets the small intestine. So these are accessory organs to digestion. We can digest food without these organs. That is why they call them accessories, but having them makes digestion of food much more easily, okay? The stomach, we really do not need to have our stomach to process nutrients. We just have to have our food in liquid form if we don't have a stomach, okay? So the liver kind of sits as a cap to the side, okay? And we have the gallbladder, which is this little green thing in the middle. So it secretes things into the intestines, okay? The hepatic duct secretes things into the gallbladder. So the gallbladder, the whole point of the gallbladder is to help secrete bile, which helps us break down fat, okay? And I like this picture of the stomach because you can see as it narrows at the end, it's the pylorus. Okay, so the pylorus is a muscle which closes the stomach. The stomach is not continually open to the small intestine here. It's not continually open to it. It opens and closes. When we have a full stomach, it's open. And when we have a very small meal, the food kind of dribbles in. But the pylorus is actually a valve, okay? And then the pancreas, which is the yellow organ here, the pancreas sits tucked in amongst the small intestine. And the pancreas, too, secretes a lot of enzymes which help us break down our food. So for number one here, produces bile, which is necessary for the digestion of fats. That would be the gallbladder. And up here I have just how you would say it. So it's pretty straightforward, the gallbladder. Okay, the passageways that carry bile, okay, are the bile ducts. The salivary glands produce saliva. Okay, the small sac-like structure that stores bile produced by the liver is the pancreas. And secretes, the small sac-like structure that stores bile. I screwed this up, guys. Number one is liver. Number two is the bile ducts. Number three is the saliva. Okay. The gallbladder stores the bile. Okay. Liver produces it, gallbladder stores it. And then the pancreas secretes insulin for carbohydrate metabolism. So you can live without your liver, okay, but you have to be very careful what you, or without a full liver, but you have to be careful how much fat you eat, okay. You can live without your gallbladder, okay, but again, you have to be careful how much fat you eat. And you can live without your pancreas, okay, but then you would have to take insulin shots. So that's why these are considered accessory organs to digestion. You can digest without them, you just have to modify your diet. This is the pathway of food, okay? I think everybody knows it goes from the mouth to the pharynx, okay, which is the back of the throat, down the esophagus, into the stomach, then it goes into the small intestine, and the small intestine has three parts: the duodenum, the jejunum, and the ileum, okay? Then the large intestine has quite a few parts, but they're pretty easy. The cecum is where it meets the small intestine, okay? Then it has the ascending colon, the transverse colon, which goes across, transverse meaning side to side, the descending colon. The sigmoid colon is the area right where it meets the rectum, okay? And then we have the 2-inch long rectum, and then the anus. The anus is the opening where feces leaves the body. The large intestines have these little tiny pouches called diverticula, okay? Plural is diverticulum. The whole purpose of these little pouches is to secrete enzymes and keep the food moving through it. When the food slows down, the diverticula, these little pouches, can get very inflamed if food does not stay in, or food is not pushed through them on a regular basis. So that's why if you hear the term diverticulitis, that's inflammation of these tiny little pouches. It occurs when food is not being continually pushed through it, okay? Because what happens is in these little sacs, the food, remember, once food goes into your body, it's not sterile, okay? And as it gets to the colon, it's also been mixed with a lot of breakdown products from our body. So there's a lot of yucky things in what is in the colon. Okay. So if the diverticulitis get all that yucky stuff stuck in these little patches, they can become inflamed very quickly. So this term, choledocholithiasis, is the root word, which is the root word that means stone. Do you guys
Lith.
remember that?
Let B.
Right, lith. Yep, absolutely. All right, so you're going to hear about 3 different kinds of hernias in this chapter. There's a hiatal hernia, okay? And what a hiatal hernia means is okay, so we've got our esophagus coming down, okay? And the esophagus passes through the diaphragm, okay? If part of the stomach starts pushing upward through the diaphragm, okay, it will make a bulge. And if it makes that bulge, this is the hernia part right here in the middle, okay? So a hiatal hernia is part of the stomach pushing upwards through the, good morning. The hiatal hernia is the part of the stomach pushing upward through the, oh my God, I'm blanking. This is what happens when you teach the diaphragm, when it pushes up through the diaphragm. So, and it bulges and it causes terrible heartburn. That's usually the first indicator. Okay. An inguinal hernia, it occurs in the inguinal area, which is the area where the top of the thigh meets the lower part of the abdomen. And this is very common in men. Okay. Part of the intestines will push down through the muscles in the lower abdomen, and it'll put pressure on, especially in men, it'll put pressure on the scrotal and testicular area. And that's one of the reasons they can find it by placing their fingers behind the scrotum. You can feel if the hernia has come through on men. With women, we don't have that option. They usually have to do an ultrasound for us. And the third type of digestive hernia is an umbilical hernia, okay? And this occurs in babies where the umbilical cord herniates into the infant. It usually is found when they are born, but sometimes it can occur a couple days after birth, where it just pushes inside towards them instead of the umbilical cord completely being outside. Okay, so these are polyps, okay? And we can have polyps in our nose, okay? But we can also have polyps in our large intestine, okay? Polyps can be removed when someone has a colonoscopy very easily. Polyps in the intestine are almost always the area that becomes cancer in colon cancer. The entire reason for having people start to have colonoscopies at the age of 50 is they can go in and find these tiny polyps and they cut them right out, and then those never become cancer. So that's one of the reasons we are seeing a huge decrease in the numbers of colon cancer, because we are doing those screens on a regular basis. Okay, so can you identify, whoops, the word parts, whoops, sorry guys, I'm going back. Can you identify the word parts to spell these 2 disorders of the gallbladder and the common bile duct? So the gallbladder, gall, C-O-H-L, coal, that's the gallbladder, okay? Lith is stone, and iasis is condition of. So if there's a condition of stones in the gallbladder, it's a cholelithiasis. And I really like this slide because it puts the gallbladder in green so you can kind of see where the gallstones might be. So if the gallstones are in the actual gallbladder, okay, it's cholelithiasis. Now, if the gallstones start working their way down into the common bile duct, then we have to change the beginning of the word. So choledoc is the common bile duct, okay? So if they're in the bile duct, it's choledocoliasis, okay? If they're in the gallbladder, it's cholelithiasis. So polypoptosis, that word can be used for anywhere where there are polyps, okay? So you'll see that term for nasal polyps, and nasal polyps cause patients a lot of issues too because they interfere with breathing, they get infected really easily. They come to the light forefront usually when someone has a cold and their sinuses get infected. So that is one of the things that happens so that we discover them. Again, they can go in, be in and taken off very easily. Okay. Hold on one second. I've got to answer tongue. She can't get in. Again, the rectal polyps very easily removed. Okay, so which is inflammation of an anatomic structure of the mouth? What do you guys think? This is a hard one. So proctitis, okay, and I haven't taught you all these words yet, so that's why you don't know them. Okay, I just want to kind of see where we're at. Proctitis is inflammation of the large intestine. Okay, the uvula, the uvulitis, the uvula is that little tiny dongle in the back of our throat. Okay, so it's actually B, because that means the back of our throat is inflamed. And esophagus is the tube that goes down our throat to our stomach, so that's not part of the mouth. So the answer is B for this one. All right, so we've got our words for these are our words that are not built from word parts, okay? So ileus refers to the intestine, okay? Intussusception is a surgical term. Irritable bowel syndrome, we hear a lot about this. It is becoming more and more commonplace for people to actually discuss that they have irritable bowel syndrome. We see tons of commercials on TV for medicine for irritable bowel syndrome. So one of the things you will see at the end of the abbreviation IBS is if they have constipation, it'll say IBS-C, and if they have diarrhea with it, it'll be IBS-D, okay? Obesity, peptic ulcer, polyp. Again, these are ones that aren't built from word parts, so they're just ones you just kind of have to remember. Ulcerative colitis, okay, volvulus, these are just all words that we can't break down any further. This is a big long word, okay, that is used to treat sleep apnea, okay? I'm going to say it. It's probably going to screw it up because you guys know me when I talk too fast. So uvulo-palato-pharyngoplasty. So there's 4 parts to it. Uvulo, okay, is the soft area in the back of your throat, okay. The palato, okay, is the area on top of your mouth. Okay, the top of your mouth is your palate. Okay, pharyngo, the back of the throat, the pharynx. Plasty. Okay, what's plasty mean?
Surgery.
Surgical repair.
Surgery.
Okay, so this is one of the things, this is a procedure that they will use for sleep apnea. Okay, but it also has to do with digestive parts, since the parts involved are part of the digestive system. They have figured out that it is probably a problem with the back of the throat that closes. As you can see in the right side, you can see it closes when people lay down. It should be open like on the left side. So one of the things they will do when they surgically repair that is put a little stent in there and open it, okay, which is pretty cool. But this is actually it's termed a digestive procedure, but it's used for sleep apnea. And again, it's pronounced uvulopalato-pharyngoplasty. Okay, a stoma, okay, is an artificial opening. When we create an artificial opening from the inside of the body to the outside of the body, okay? So if someone has an artificial opening of the ileum, okay, that's the small intestine, it's an ileostomy, okay? And we can remove waste from that. They put a bag on with it, and we can remove waste from the intestines that way. If there's a creation of an artificial opening into the large intestine or the colon, okay, it's a colostomy. So these are some ways we have allowed people to bypass their internal systems. Sometimes if someone has large intestine or colon cancer, and we've had to remove a great deal of their colon, they obviously can't digest their food. So they can't pass it out of their system. Okay. So we can take it out in a bag and basically bypass the anus and rectum. The ileostomy is when people have problems with their small intestine and they've lost a great deal of it, or maybe they've lost both their colon and their large intestine. So we can actually remove the waste products and bypass the lower parts of the intestine. While it's not exactly pleasant, people can live like this for years, healthy lives. And most people who have a colostomy, you would absolutely never know if they've had one of these two procedures, because it's very discreet. The bags are discreet. They just have to be changed a little bit more often, because obviously they get filled very quickly. So this is an instrument called a colonoscope, okay? A colonoscope, I've seen it used both way. It's used for visual examination of the colon, okay? So it goes up through the anus and rectum, okay? And they look at the whole large intestine, all 6 feet of the large intestine. And the word colon and large intestine are used interchangeably, okay? So when you have a colonoscopy, the whole day before is spent completely clearing out your digestive system. Okay. Yes, you have to take laxatives, you have to take stool softeners, you have to drink a liquid diet, basically completely clear it out. Okay. So that they can look at all 6 feet of it very clearly. And they can then find if there's any polyps on it. And how they remove these polyps is so interesting. They use a snare, okay? And the snare basically is just a little metal probe, okay? And they push the snare out of the probe and it gets big, and they put it around the polyp and then they pull the wire back in, and when they pull the wire back in, it basically lops off the polyp. Then they have another connector that takes the polyps, and they will send those polyps to be checked. And most of the time when polyps are very small, they are not cancerous at all, okay? But the whole reason for removing the polyps is because if there are any cancer cells in the large intestine, they migrate to these polyps and they grow very quickly. Okay, here's another non-surgical term, okay? This is called anastomosis, okay? And this is one of my terms that students learn on Grey's Anatomy all the time because they're surgical residents and they are always performing an anastomosis. An anastomosis can occur anywhere in the body, okay? All it means is you are surgically attaching two parts, okay? So the top one is an example. If they had to cut out 2 feet of small intestine that were so inflamed that they were hemorrhaging, okay? They would cut the bad part out, then they would take the healthy ends and surgically stitch them together. So that is called an end-to-end anastomosis, okay? You will see in other different, using other different organs, or if they're working on veins, anything like that, they can do an end-to-side anastomosis, okay? That can be done, that's done a lot of times with arteries and veins. And then you can have a side-to-side anastomosis. If they need to take 2 small veins and make it into a larger vein to transplant somewhere else in the body, they can do a side-to-side anastomosis. So again, the word anastomosis just means to join 2 things surgically. Okay. Which term refers to the creation of an artificial opening? Remember that the suffix stomy means artificial opening. Okay, so colostomy means we are creating an artificial opening into the colon. Now, I don't know if you guys want to look at these or not, but I like pictures. So I just put some normal pictures or some interesting pictures up. Picture A is what a normal colon looks like. This is a picture from a colonoscopy, okay? Picture B is diverticulosis. These, you can see these little tiny pockets here are the diverticuli, and there's a lot of mucus around them, which is telling me that they probably are infected, okay? C, oh, excuse me, that was B. B, whoops, let me go back. B, diverticulosis. You can see there's a lot of yellow and infection and a lot of pus around these little diverticulosis pockets. C is a colon polyp, okay? That is this area right here, okay? The colon should be wide open, but this is a polyp that's grown on the side, so they would lop that off. And D is an unfortunate picture. This is what the inside of a cancerous colon looks like, okay? This is pretty bad. So if they were doing a colonoscopy and saw this for the first time, that patient probably wouldn't have a lot of time to live. Okay, a barium enema. Okay, a barium enema is also called a lower GI series. And what they do is they literally put a tube in your anus and inject barium and in an enema form or a liquid form up into your intestine, to your to your large intestine. The whole point of the barium is it has metal in it. So when you take a picture with the x-ray, the metal gives the x-ray something to bounce off of, because normally the intestines are a soft tissue organ, so soft tissue organs don't x-ray well. When we inject barium with the metal in it, it provides a background for us to actually visualize the colon. You can see if the barium has gone through completely, if it's gotten stopped somewhere, and that indicates a blockage. But we can tell an awful lot by a barium enema. Now, while it is not a completely pleasant experience, a barium enema is much less prep than a complete colonoscopy. Okay, so that's one of the reasons. If you go to the emergency room and you're having some issues and say you haven't had a bowel movement for 3 or 4 days, they'll recommend a barium enema first before they'll do a colonoscopy, because you do not have to be anesthetized to have a barium enema. You do have to be anesthetized to have the colonoscopy. So this is a sonogram of a gallbladder, okay? The little black area in the middle is the gallbladder, okay? And right here where it says ST, that is a stone, okay? That is blocking the bile duct, the gallbladder duct, okay? It's blocking the duct. So this is a condition of gallstones, okay? This is an endoscopic retrograde choleangiopancreatography. So let's break that word down. Tography, we know that's a picture of, okay? Pancreas, the pancreas. Choleangio, okay? Of the bile duct and the pancreas, okay? So what they have done here is they have injected contrast media into the pancreas to see if it's blocked in any way. This, I like to say, scorpion-like area here is the common bile duct, okay? This tiny little thin duct is the pancreatic duct. So when they put contrast media in, again, the contrast media has a metal in it, so we can see it better on X-ray. And the endoscope has gone down through the patient's throat, and it allows us to see what's going on in there. Okay. So normally when they do an endoscope, okay, a gastroenterologist is going to do it. They usually lay you on your side. They do sedate you because people will automatically, it's your automatic reflex to want to vomit something in your stomach which doesn't belong in there. So they sedate you and they calm your nervous system down, your vagus nerve system down, so that you don't spit the endoscope back out, okay? But they can go in pretty far from the top down to see anything that's going on in the esophagus, the back of the throat, the stomach, and the very beginning portion of the large of the small intestine. Okay. Again, not the most pleasant experience, which is why they put people out for this. All right, so these are two terms which are used interchangeably to mean the rectum, procto and recto. And I don't know why we have to have two terms. Again, it doesn't make any sense, but it is what it is. So, you know, I think we've all heard of the term proctologist, the person who studies the rectum and the large intestine, okay? So proctology is the study of it. Proctoscopy is the visual examination of the rectum, okay? The proctoscope is what's used for the rectum. Now remember, when we're talking about the rectum, we're talking about the anus and the rectum, the last 2 inches before things are eliminated from our body, okay? when we are talking about the actual rectum in, say, a patient report, they will use recto, okay? So usually proctoscope, procto is used in the terms of assessing what's going on with the rectum. Rectum is used traditionally in the medical reports, okay? So a rectocele would be a protrusion of the rectum, okay? Pertaining to the colon of the rectum is colorectal. Pertaining to the rectum is rectal. All right, you don't hear pertaining to the rectum as proctal, okay? So as you start using these terms a little more frequently, they will become much more easily to discern when you use proct and when you use rectum. Okay, hematochezia. Okay, hematochezia is a complementary term not built from word parts. Okay, so hemato means blood. Okay, chezo is the Greek word for feces. Okay, so hematochezia means that there is blood in your feces. And anytime you have blood in your feces, it is an abnormal condition. Okay. It means that you are passing visibly bloody feces. Okay. But then we break that term hematochezia down a little more in the next slide. Okay. If you have melena, that means your stool is black and it looks like road tar. And the reason for that is it usually contains digested blood. That is a trigger that there's usually bleeding in the upper GI tract or in the small intestine, okay? Because it's had a chance to break down as it's passed through the digestive tract, okay? If there is bright red blood in the digestive tract, if it's bright red hematochezia, that means there's usually an active bleed in the lower intestine because it has not had a chance to break down, so it's not black. If the blood in the stool is dark, okay, it's had a chance to break down and usually signifies the upper GI. If it's bright red, it usually signifies a bleed in the lower or in the colon. Okay. Hematemesis means you're vomiting blood. Okay, and they too the blood that you vomit can be two different colors. Okay, if you have an active ulcer, okay, it's going to be red. All right, or if there's some type of trauma to the belly, it's going to be red. But if it's been bleeding for a while and it's had a chance to break down, it's going to look black and it's going to look like coffee grounds usually. Okay, so just some things to take into account for when you start, working as a medical assistant or in wherever you're progressing to. Those are some different ways we categorize the blood that's coming out of people abnormally. Okay, emesis is synonymous with vomiting. Yes, you guys know that's true. Okay, a peg tube. Okay, a peg tube is short for a percutaneous endoscopic gastrostomy. Okay, so this is a tube which is put into the stomach through the abdominal wall to administer liquids for nutrition and hydration. So a peg tube, okay, goes right from the outside straight through the abdominal wall into the stomach, okay? And it's short for percutaneous through the skin, endoscopic, okay, gastrostomy. All right, let's just take a few minutes to go through some abbreviations, okay? A series of radiographic images taken of the large intestine after the contrast agent barium has been administered rectally is a barium enema. That's a BE, okay? Remember, we talked about periodic disturbances of bowel function, which can be diarrhea, constipation, or both. That's IBS. If it's diarrhea, it's -D. If it's constipation, it's -C. Okay? UPPP, that is the surgical repair of the uvula, the palate, and the pharynx. That is what's used to help with sleep apnea. Okay? An EGD tube is a visual examination of the esophagus, stomach, and duodenum. Okay. Removal of the colon, rectum, and anal sphincter through both abdominal and perineal approaches is APR. Okay. Abdominal approach means they go in through the abdomen. Perineal approach means they go in through the anus. Okay. All right, so I'm going to leave you ladies to tackle your medical terms in these medical statements, okay? But do you guys have any questions for me? No? All right, well, it was really good to see all of you again this week. So have a great week. If you did not get the chance, I'm looking at you guys. If you didn't get the chance to post to the discussion post, feel free to go to back to last week and add to the discussion post. But other than that, I will see you all next week, okay? Let me know if you need me in the meantime.
Thank you.
All right, see you girls.
See you.